So we're going to go through the way we started today, talking about hyponatremia. And again, this key issue that I think is important to ram home, that this is a CNS disorder, hyponatremia, and this relationship between osmolality and vasopressin release, and the fact that that's physiologically regulated in hypovolemia and hypervolemia and so on, is helpful to think about at the bedside when we change volume status in a hypovolemic patient and so on. And this diagnostic algorithm you all are very familiar with. And again, to remember how we use this, where this urine sodium of less than 20 comes from this paper many years ago, separating patients that respond to volume with an increase in serum sodium based on the urine sodium as a subclinical indicator of volume, an indicator of subclinical volume depletion. And then again, we talked about the various subtypes of SIDH based on the pattern of vasopressin, either this unregulated erratic form, a baseline increase in vasopressin with normal regulation, the reset osmostat, or the patients with suppressed AVP. So here's a case of hyponatremia. These are two young boys that are 3 and 2.5 years old. This particular syndrome has also been reported in people presenting in the age of 70, even though it's a genetic disorder. So everything in the lab work looks like SIDH with one exception, and that's this set of blood work here, where both of them have suppressed vasopressins of less than 1. So this really looks like SIDH with that one distinction. So how would you characterize their clinical syndrome? SIDH with increased circulating oxytocin, mineralocorticoid resistance and hypovolemic hyponatremia, coexistence central DI and renal salt wasting, which seems superficially reasonable given the low vasopressin, normotonic hyponatremia, vasopressin levels are appropriately suppressed, increased renal sensitivity to vasopressin, vasopressin levels are appropriately suppressed. Well, if you look at their urine sodium, they're not particularly low or particularly high. This looks like somebody, or it doesn't look like sodium wasting per se. And they clearly have a reduced serum osmolality. In both cases, this was measured at 252 and 247. So many of these suggestions are not right. This is not normotonic hyponatremia or pseudohyponatremia. And as you may have guessed, the correct diagnosis here is increased renal sensitivity to vasopressin. Vasopressin levels are appropriately suppressed. So these patients have 2 point mutations and 1 specific residue of the vasopressin receptor that cause a gain of function in the V2 receptor. And all of the patients with this syndrome have been found to have mutations of this particular residue in various flavors. And if you put these mutations into the vasopressin receptor and look at the response in cyclic AMP to, I believe this was in response to vasopressin stimulation. Here's the wild type receptor. Here's a mutant that's associated with nephrogenic DI. And here are the mutations that are found in these patients where you get this huge gain of function in the V2 receptor. So this is called nephrogenic SIADH. It targets this residue that is involved with different residues in it in nephrogenic DI. So this particular residue, when it's mutated, causes a gain of function in the vasopressin receptor. So NSIAD is perhaps the worst possible acronym you could imagine for a disorder, because it's almost impossible to type that out without writing NSAID. But it means basically what it sounds like, nephrogenic SIADH. And this is the kind of, this is old enough now, 6 years or so, and there have been enough patients described with this syndrome that you might encounter this on the boards. And again, as I mentioned earlier today, this syndrome explains these patients that Robertson described many years ago. At least a subtype of them have gain of function mutations in the V2 receptor. And these patients have a variable phenotype. One patient was discovered in his 70s because he was resistant to tolvaptan, and they found an entire kindred related to him that had this disorder. We need to, as I mentioned in this morning and then again at lunchtime, you need to sort of subdivide both physiologically and pathophysiologically and management-wise. You need to subdivide hyponatremia into acute hyponatremia and chronic hyponatremia. and just have at your fingertips this differential of acute hyponatremia and the sort of syndromes where you can see it and where you need to be aware of it and what the pathophysiology is. Chronic hyponatremia, again, this physiologic definition that it's of greater than 48 hours or of unknown duration. So 48 hours is the window in which you can reduce cerebral osmolytes in response to hyponatremia. And that CNS response is what induces the sensitivity to osmotic demyelination. And as I said, we are classically taught that these symptoms are absent in chronic hyponatremia, but it's very clear now that many patients will have nausea or vomiting, ataxia, confusion, and falls, and so on. So it may be a different pathophysiology than acute hyponatremia, where most of it's cerebral edema, but it is very clear now that there are neurological consequences of chronic hyponatremia. And as I mentioned, the newer development that chronic hyponatremia seems to cause osteoporosis, and part of the reason that there's an increased risk of falls with hyponatremia is this relationship to bone density. So this is something we're going to hear about a lot in the near future. Treatment of hyponatremia, we need to talk about management of acute symptomatic hyponatremia, and we talked about the management of chronic hyponatremia, fluid restriction, Lasix and salt tablets, demeclocycline, which is still available. The problem there is nephrotoxicity in some patients. And the vasopressin antagonists are, of course, less toxic, but we're not entirely clear when we should be using these in patients with hyponatremia. And hopefully we agree that if you have a patient with acute symptomatic hyponatremia, you need to give them hypertonic saline. They need to be oxygenated. They need loop diuretics, mostly, as we said, to get rid of this issue of the pulmonary edema if they have that. We talked about the various formulas. We didn't go through all of them, but if you're interested, this is a terrific review of SIDH, which is still reasonably current. Some of them clearly are more complicated than others, but this key issue that whatever you do, if you're sitting down and calculating how much hypertonic saline to give patient X, you need to reevaluate that over time by following the serum sodium, following the urine osmolality, because the physiology will change as you start perturbing that patient and giving them hypertonic saline. And this is shown by the gross underestimation of serum sodium changes in patients using the Adrogium-Medias formula versus just following them. This issue of what to do if you overcorrect the treatment of osmotic demyelination. The key here is this issue of giving both DDAVP and D5W to reinduce hyponatremia. And most of the time, or much of the time, the patients that overcorrect, giving back D5W is not adequate because vasopressin has gone away. So no matter how much free water you give them, they're not going to either bring their serum sodium down or change the rate of correction. So you need to give them back some vasopressin bioactivity, and you need to give them some DDAVP as well. And again, this paper from Rick Stearns' group on doing that retrospectively in many patients, it's relatively safe, but the problem is this sort of herky-jerky serum sodium change that you see when you do this. It goes down and then it goes back up, and it's very hard to manage this. And in the future, I think we're going to be doing more BID DDAVP and combined with hypertonic saline to slowly, in a more controlled fashion, increase serum sodium in patients in whom we want to change it acutely. Also, you need to think about the differential of those hyponatremic causes that are associated with overcorrection. That includes hypovolemic hyponatremia after you've given them volume resuscitation with saline and you reduce circulating vasopressin. Hypopituitarism with secondary adrenal failure after treatment with cortisol and a drop in vasopressin. Thiazide-associated hyponatremia after you stop the drug and or you give saline hydration. And any rapid spontaneous resolution of SIADH or of a non-osmotic increase in AVP. And the classic is post-op nausea and pain, where people can you can overcorrect as they stop the vasopressin release. We'll talk a little bit about some of the take-home messages in potassium. Again, this key issue that you need to think of the principal cell and this relationship between ENaC activity, the epithelial sodium channel, the lumen-negative potential difference, and the fact that that drives potassium secretion through at least two types of apical K channels. So there are many, many consequences to this. Obviously, one is if you inhibit ENaC or you activate ENaC one way or another, you're going to change potassium balance. So if you inhibit ENaC, you're going to develop hyperkalemia. Because the adjacent intercalated cells also depend on this lumen negative potential difference, you will also get a bit of a metabolic acidosis if you inhibit ENaC. If you have overactivity of ENaC, you tend to get hypokalemia. That plays a big role in metabolic alkalosis, as we talked about, and that hypokalemia and the increase of the changes in potassium hydrogen exchange in the adjacent cells become important. We mentioned the fact that aldo is a very important regulator of potassium excretion, so high levels of aldosterone increase kaliuresis at any given plasma potassium, whereas low levels or lower submaximal levels of aldosterone decrease your ability to get rid of a potassium load. But the important issue is that potassium, the apical K channels are independently regulated by potassium intake. So that in the setting of high potassium intake, you have a marked increase in density of these channels. But if potassium intake and circulating potassium is low, these channels are basically shut off in the principal cell. And that serves as a brake that isn't entirely effective because we know that people do become hypokalemic. But that serves as an important brake on potassium excretion in settings of increased aldosterone bioactivity. And the other take-home message is that aldosterone and ENaC really increase the driving force for potassium excretion. So they really set the stage, and then the density of K channels is what determines how much potassium is secreted. Causes of hyperkalemia, we've talked about, and Alan went through many cases that are helpful. It's important, you might want to just quickly go to a question first as we're talking about causes of hyperkalemia. You're asked to evaluate moderate variable hyperkalemia in a 26-year-old woman with type 1 diabetes since the age of 10. She has hypertension and proteinuria with a urine protein creatinine ratio of 1. She is on lisinopril 40 milligrams a day, insulin, PRN, NSAIDs for headache, and oral contraceptive. And she has a potassium of 5.2 and a TTKG, which is inappropriate for her level of hyperkalemia. So it should be greater than 7. This is clearly an inappropriate renal response. She has some degree of renal insufficiency as well. Which of the following factors is most likely to have contributed to her risk of hyperkalemia? And this is one of these tricky questions because all of them seem modestly right. And it's really what is the most likely answer. Underlying renal artery stenosis, excessive dietary intake of potassium, subclinical adrenal insufficiency, hyporeninemic hypoaldosteronism, or her oral contraceptive. Any takers? Well, the answer would be her oral contraceptive. Obviously, many of these other things may be an important factor, but this is also to bring up this issue of drospirenone and hyperkalemia. Drospirenone 3 milligrams is the progesterone component of several oral contraceptives, including Yasmin, and Yasminel. It also inhibits the mineralocorticoid receptor, and 3 milligrams is basically equivalent to 25 milligrams of spironolactone. Oral contraceptives, including this drospirenone, can reduce blood pressure because of this anti-mineralocorticoid activity, but they don't tend to cause hyperkalemia in healthy women. However, there is an increased risk of hyperkalemia in patients with underlying predispositions. For example, this patient who's got diabetes and early diabetic nephropathy and is taking an ACE inhibitor. So again, we talked about the many medications that can cause hyperkalemia. We talked about the mechanism of type 4 RTA, how NSAIDs, for example, will inhibit renin secretion by the kidney, and talked now about drospirenone, which is another aldosterone antagonist that's worth remembering. It's a favorite board's question to talk about trimethoprim, which is an inhibitor of ENaC. Pentamidine also is an inhibitor of ENaC, so that these can cause a hyperkalemia with or without some degree of acidosis in patients treated with these antibiotics. The other issue with trimethoprim is it actually can cause hypovolemic hyponatremia by virtue of its diuretic effect. So particularly in elderly patients, you will see patients who are put on Bactrim and come in with hypovolemic hyponatremia, where this diuretic is really the major cause. Hypokalemia causes, we talked about the non-renal loss, this issue of this novel new cause of secretory potassium diarrhea in Ogilvie syndrome due to an activation of colonic K channel. That's the major new development in this particular area. We talked about renal loss and hypokalemia and how magnesium deficiency, chronic whole body magnesium deficiency, causes hypokalemia or exacerbates hypokalemia by inhibiting muscle NAK ATPase with a secondary kaliuresis, but also probably by reducing magnesium-dependent block of this secretory K channel. So there's potassium, inappropriate potassium excretion probably in the setting of hypomagnesemia. And this key issue that if you have a hypomagnesiemic patient, you really simply must replete the magnesium as you replete the potassium, or you'll have very little effect of replacing potassium alone. Consequences of hyperkalemia. In the acidosis talk, we talked about the fact that there's this interaction at the thick ascending limb between ammonium and potassium. So if you put animals on a high potassium diet, they become acidemic. And it's largely because of this competition between potassium and ammonium in the thick ascending limb that then reduces available ammonium in the distal nephron for excretion. And we talked about some of the issues in treatment of hyperkalemia, but I think the single biggest new development is this issue of ischemic colitis with K-exolate, and the fact that we need to really think about using K-exolate when we do, because of this new FDA advisory that you should not administer sodium polystyrene with sorbitol. And Alan had a case as well that we talked about. The key thing, though, is it's not just those high-risk patients, the post-op patients that are at risk for colonic necrosis. It's becoming increasingly clear that just about anybody that gets K-exolate with sorbitol is at risk for colonic necrosis. So I tend to tell patients, if I'm giving them K-exolate, I tend to document that I've discussed that with them. I think in this day and age we need to do that. There will be better potassium binding resins, hopefully, that will be coming out in the near future that don't have these issues. So down the road, hopefully we'll have a better, safer potassium binder that we can even use more aggressively in patients, for example, that are on ACE inhibitors or angiotensin receptor blockers. But for now, we're in a bit of a gray area as to when we can or when we should be giving K-exolate. There's really many places don't have solid sodium polystyrene available without sorbitol. In acid-base disorders, we talked about through various cases and so on today, we talked about some of the newer issues in anti-GAP acidosis, propylene glycol. I have some slides in my early talk, and Alan talked about a case. Acetaminophen and 5-oxoprolinuria, I think both of us talked about, is a very important newer cause of anion gap acidosis that is not uncommon. So I think now that this has been appreciated, it is being diagnosed on a much more frequent basis. So you need to be aware of that just for pure clinical care. We talked about the spurious causes of a low anion gap, particularly this adjustment in the albumin, and how that can lead to missing someone with subclinical lactic acidosis. Several times we talked about the delta-delta. I think some of Alan's cases went through that as well. And the fact that this isn't really a perfect test, but that simple concept that you need to look at the change in the anion gap and the change in the bicarbonate and just use simple physiology and simple logic to decide if there's another primary acid-base disorder. Finally, when we went to the renal tubular acidosis, remember that bicarbonate is reabsorbed by the proximal tubule through this concerted mechanism that involves apical carbonic anhydrase, intracellular carbonic anhydrase, the sodium proton exchanger, and then the basolateral sodium bicarbonate transporter that is genetically involved in proximal renal tubular acidosis. The pathophysiology of proximal renal tubular acidosis is this reduced proximal bicarbonate reabsorption overwhelms the distal nephron. You have an increase in chloride reabsorption, giving you a hyperchloremic acidosis. You decrease the filtered load of bicarbonate to decrease distal reabsorption, and your urine pH goes down. And at a steady state, these patients will have a bicarbonate that is between 15 and 18 milliequivalents. So not quite as dramatic an acidosis as in distal RTA, with urine pH that's less than 5.5. And you need to particularly distinguish these from patients with hypokalemic distal RTA. So not every patient will have Sjogren's and be obviously hypokalemic distal RTA. Not every patient will clearly have a Fanconi syndrome, and so on and so forth. And you can do that by looking at the fractional excretion of bicarbonate and comparing that to the response. So the patients with proximal RTA will tend to waste bicarbonate and have a very high fractional excretion of bicarbonate, whereas those with hypokalemic distal RTA, you'll see minimal change in urine pH and fractional excretion of bicarbonate should be relatively low. In terms of distal RTA, I mentioned this issue that it's probably easier to think about the pathophysiology if you classify it in these 4 functional subtypes of distal RTA. So the patients that have a defective protons HATPase, which is a secretory defect, and the classic of that, of course, is genetic deficiency in the HATPase. An unfavorable electrical gradient for proton secretion. Remember that the proton secretion is electrogenic, so you want to have that lumen negative potential difference just as you need that for potassium secretion. This rare cause of back diffusion of protons, which is really just seen in amphotericin toxicity. And again, this issue of insufficient delivery of ammonia to the distal nephron, and that's what you see in hyperkalemia, where just bringing the potassium down can actually increase the serum bicarbonate somewhat. We talked about the various causes of hypokalemic distal RTA. Far and away the most common ones that we see in adult medicine are lupus and Sjogren's, but there are many hereditary syndromes that might appear on the boards. The reason I find these important is just to think about the pathophysiology. So this HATPase, as I said, that's the sort of sine qua non of a secretory defect, and then you sort of remember some of the pathophysiology as you go along. And again, many of these proteins are involved in distal RTA of various hereditary causes. But remember also that if you lose the actual cell type, you'll lose this issue of HKATPase activity. So that's partly why patients with distal RTA have a significant hypokalemia. Hyperkalemic distal RTA, we tend to think of that as mostly type 4 RTA. But remember that that occurs also with adrenal insufficiency, with mineralocorticoid resistance, and with drug-induced causes such as amiloride, triamptorine, pentamidine, and so forth. Finally, when we talk about metabolic alkalosis, I mentioned that it's probably easier to think of it in terms of this subclassification, looking at chloride depletion syndromes such as GI losses and renal losses. And Alan talked a lot about how Bartter syndrome and Gittelman syndrome can be distinguished based on the changes in urine electrolytes versus patients that are volume depleted and a GI loss of chloride. Mineralocorticoid excess syndromes, primary hyperaldosteronism, glucocorticoid remedial hyperaldosteronism. The apparent mineralocorticoid excess syndromes, Little syndrome is one of these. The syndrome of apparent mineralocorticoid excess, which is 11-beta-HSD2 deficiency, where you don't inhibit the generation of cortisone and you have activation of the mineralocorticoid receptor by glucocorticoids. And then finally, we discussed that not all of these patients fit into perfect categorizations. Patients with severe hypokalemia, maybe with a chloride depletion syndrome, will also have an additional cause for metabolic alkalosis. And clearly, potassium deficiency plays a critical role in the generation of metabolic alkalosis. But these patients in particular, as we talked about at lunch, can have a relatively high urine chloride. The diagnostic algorithm that we talked about at length in lunch is important, but again, not everybody fits into this issue of hypochloremic and chloride responsive metabolic alkalosis.
Well, it is important when we analyze the kidney, the same way to some extent when you analyze the syndromes and the patient's symptoms, as to what is the underlying mechanism. Because we cannot yet treat patients by the cause. We don't have the cause of kidney diseases very often, or the cause is very hidden or indirect. And therefore, we can only hope to treat the mechanism, the underlying abnormality, the underlying pathophysiology, and in the hopes of then correcting the clinical problem. And this is just a list of the many, oh yeah, I see it. So this is just a list of the potential mechanisms that are involved. Some of them are relatively newly discovered, and I would point that out. In particular, somewhere here is abnormalities in complement regulatory proteins. This has become a very key point, a pathophysiologic mechanism with several groups of diseases that probably have been misdiagnosed in the past. And I will mention that as we go along. Of course, there's always the congenital and the genetic abnormalities. Many new conditions are being described now that are clearly genetic predispositions or even genetic diseases that we understand better. They may be very rare, but they allow us to understand overall the field much better. The classic immune mechanism are, of course, very important. You all know about the metabolic diseases, not just diabetes and hyperuricemia and things like that, but also obesity and how the body mass index influences the kidney function and the kidney structure. And so this is just a compilation, and we will touch upon as we go through the diseases. Now, more clinically, you tend to group diseases into those that are predominantly proteinuric, and most importantly, those in which the proteinuria leads to the full nephrotic syndrome versus those proteinuric conditions that do not lead necessarily to the nephrotic syndrome, and they are more slowly progressive. And the other group of diseases are the hematuria, of course. And all these diseases, both the proteinuric as well as the hematuric diseases, can be either present with relatively preserved function. And in the case of a hematuric condition with an active sediment, you would probably think of a focal disease such as IgA nephropathy, at least at the beginning, or thin basement membrane disease. But you can also have the hematuric conditions with loss of kidney function acutely or rapidly progressive, if you want, and hence the terminology of your syndromes. The nephrotic syndrome, full nephrotic syndrome with edema, and then the nephritic conditions with an active sediment, with renal failure, with acute kidney failure, with rapidly progressive kidney failure, or with no renal failure. And these are basically the basic syndromes. In the same way, you analyze a patient by syndrome first, and then you come to a differential diagnosis. By the same token, as a morphologist, we look at the pattern of injury. And these patterns of injury are the equivalent of your syndromes. And even though they sometimes have the same name as a disease entity that you know and that we know of the chapters in the textbooks, this is actually a pattern of injury. And therefore, membranous nephropathy, a membranoproliferative glomerulonephritis, and crescentic glomerulonephritis, and all these patterns, the phenomenology, the way the biopsy presents itself to us in its abnormality, similar to the syndromes to you, these patterns of injury are extremely nonspecific. So instead of organizing a talk on glomerulonephritis based on the chapters in the classic textbooks, I prefer to present you with this because this is the way we encounter the patient through the biopsy. The patterns of injury is what we see, what we recognize, and hence we need to dissect these patterns further to figure out within each pattern what potential mechanism is behind that, which is in common to these patterns, and then come to a clinical pathologic correlation in terms of what disease entity is giving this patient a membranous nephropathy in this particular moment or a membranoproliferative in any particular moment. You have to remember that the glomerulus is quite a unique structure. Unique not only in its makeup, in its composition molecularly. Remember, there are diseases that only affect the glomerulus, genetic diseases, because there are unique proteins expressed only in this microcirculation, in no other microcirculation in the body. Think of Goodpasture syndrome or all the genetic diseases that we now understand in terms of basement membrane or the podocytopathies that are unique to this microcirculation and not any other microcirculation. Therefore, this is becoming more and more complex, that much more interesting, of course, because there are many differentiations within these cells that allow this uniqueness of the structure. So we look usually, by the way, I wanted to point out that this is not just unique in its structure, but also in its function. Remember, this is a glomerulus, a microcirculation is placed between two resistance vessels, the afferent and the efferent arteriole. And therefore, in many respects, this capillary network behaves more like a modified arteriole. It is a modified arteriole in which the smooth muscle cell that normally is surrounding the vessel, in this case it is relegated to the mesangial areas, which is the smooth muscle-like cell, which we call the mesangial cell. And therefore it is a modified arteriole, and whenever you have arteriolar disease elsewhere in the body, in systemic conditions, you will have a glomerulitis in the kidney. A classic example, when you have a patient with vasculitis elsewhere in the body, that manifests itself as a venulitis or an arteriolitis or a leukocytoclastic vasculitis. In the kidney, it will manifest itself as a necrotizing glomerulitis and eventually a crescentic glomerulonephritis. So there is many things that are in common between the arterioles and the glomerular microcirculation. Important for you to understand is the levels. We will see diseases that affect predominantly the proximal layers of the capillary wall, namely the endothelium and the lamina rara interna. Those are usually the result and conditions that are associated with inflammation, nephritis, and then we will discuss the diseases that affect predominantly the distal areas of this capillary wall, of this filter, if you want, namely the porocytes and the lamina rara externa, and those diseases tend to be proteinuric, even nephrotic, with a full nephrotic syndrome. So let's go through this. I don't need to define for you the nephrotic syndrome. Just remember that we tend to forget that nephrotic range proteinuria, let's say 4 or 5 grams of proteinuria, is not synonymous with a nephrotic syndrome. There are patients that have 5 or 6 grams of proteinuria without edema and without the full nephrotic syndrome. And the differential diagnosis in those patients is different from those that have 6, 7, or 8 grams, but with the full nephrotic syndrome. So I make emphasis on this because I think it is important. Very often we get biopsies that says the nephrotic syndrome. And then when we call, and then it is 4 grams of proteinuria, but no edema, and not sudden onset, but rather slowly progressive proteinuria. And that has a different differential diagnosis than if the patient were to present suddenly with a full nephrotic syndrome within a few days or within a few weeks. So it is important to keep those ideas kind of separate. The structural patterns usually associated with this syndrome are these. Epithelial cell disease, I wish we could change this, or minimal change disease, I wish we could change this pattern to a diffuse podocytopathy, because that's what it is in reality, a diffuse injury to the podocytes. This can be genetic, or it can be acquired. Now, another diffuse podocytopathy is focal and segmental sclerosis. Now, you add to this pattern of injury, normal by light microscopy, you add a focal and segmental glomerulosclerosis. Now, this is not a single disease entity, and we will dissect this further. Also, membranous nephropathy is a diffuse podocytopathy. In this case, added an immune complex disease in the subepithelial layer of the capillary wall. So these are the diffuse podocytopathies, if you want, the acquired diffuse podocytopathies that, as a consequence, present with a full nephrotic syndrome. So all nephrotic conditions as a structural counterpart will have a heavy proteinuria. It's the simplification, the diffuse damage, or what we call fusion of the foot processes of the glomerular visceral epithelial cell. That is in common to the nephrotic syndrome. And here you have such an example in which the podocytes have lost completely the interdigitations. You also notice there are numerous nuclei here, that these cells